Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Hi, and let's get started with Chapter 1 in Abnormal Psychology. Most people would agree that a parent who throws themselves in front of a train while holding their young child is not behaving normally. But how do we distinguish between someone who is temporarily unable to get out of bed because they're going through a traumatic divorce and someone who is suffering from severe depression? Today, tomorrow, you'll likely get out of bed, eat breakfast, go to class, study a bit, and at the end of the day, enjoy the company of your friends before falling asleep in your own bed. It probably didn't occur to you that many physically healthy people are unable to do some or any of these things. What they have in common is a psychological disorder, a psychological dysfunction within the individual that is associated with distress, impairment, and in the functioning and response that is not typical or culturally expected. So, how can we know whether a behavior is normal or abnormal? At what point do our fears, thoughts, moods, and or actions move from normal to mentally disturbed? We'll explore the many psychological disorders, their symptoms, and their possible causes, along with treatments in this course. Just before we start, there's two really important points that I really need to make, and I'll probably repeat them throughout the course. First is, do not self-diagnose and don't diagnose somebody else. We're not diagnosticians. We don't have years of experience and familiarity with the DSM-5, that's the diagnostic tool used to make appropriate diagnoses, and so we really aren't in a position to make those kinds of diagnoses. So please, don't. Secondly, you likely have, as everybody does, a certain degree of belief or understanding of a particular disorder is like, or what you think a particular disorder is like. Perhaps you've said this, oh, my OCD is kicking in, because you like to put your notes in a particular order and color coding, or you describe yourself as being depressed or having depression as a result of a poor test score. However, in a couple of days you're engaged with your friends, you're laughing, and you're socializing. We are in fact going to explore accurate, data-based, empirical evidence about psychological disorders, what they are and what they're not. For someone who's diagnosed by a professional, hearing others who self-diagnose or use terms very loosely, say, how about their OCD or their depression is active, can be very discouraging and reflect a misunderstanding of what they themselves are generally experiencing. So please, don't self-diagnose or diagnose others, and please be sensitive about how you're using terms that really don't reflect the reality of what those situations are. Okay? Okay, let's look first at the obvious first questions. What is abnormal behavior and what is abnormal psychology? In your textbook, abnormal psychology is the branch of science of psychology that addresses the description, the causes, and the treatment of abnormal behavior patterns. Now, various criteria are used to define abnormal behavior. Psychologists generally consider behavior to be abnormal when it meets some combination of the following criteria. So the criteria we're going to use is, when is behavior abnormal, and what kind of questions should we be asking? Let's review a few of these questions. Is the behavior unusual or infrequent? Is the behavior socially unacceptable or in violation of social norms? Now, if you watched, and I hope you did, the Am I an Online Learner video, you know that I wear shorts all year round. That violates a social norm. Most people don't wear shorts in the wintertime. Think of something that is unusual, such as dressing in a non-conforming way in class or at a social gathering, or doing something that is socially unacceptable, such as singing on the bus or eating spaghetti in a restaurant with your fingers. Then go out and do the behavior. Now please choose, for this experiment, please choose or avoid doing anything that is illegal or contrary to others' rights. After you do this experiment, if you so choose, reflect on how difficult it was to carry out behavior, your feelings about it, and how did others react. This exercise usually helps us appreciate the importance of social norms. 3. Is the behavior fraught with misperceptions or misinterpretations of reality? Does the behavior get associated with states of severe personal stress? Is the behavior maladaptive or self-defeating? Is the behavior dangerous to self or others? Now, these don't definitively define normal and abnormal, but it gives us some idea through questioning how to define things as being more at risk for psychological disorders and not at risk. So what factors affect our perspective about abnormal? Because it's not universal. The determination of which behavior patterns are deemed abnormal depends on cultural beliefs and expectations. Concepts of health and illness may also have different meaning in different cultures. Abnormal behavior patterns may take different forms in different cultures, and societal views of that abnormal behavior can vary across cultures. We need to consider how people in different cultures experience states of emotional distress, including depression and anxiety, rather than imposing our perspective on them. Our expression of distress, or when to be distressed, is not universal. Failure to recognize cultural differences in what is deemed normal and abnormal behavior can lead to inadequate or inappropriate diagnoses and treatments. Most behavior can be placed on a continuum, where individuals with no symptoms or those struggling but do not meet the criteria for abnormality, while individuals in the mild, moderate, and severe display symptoms meet criteria for abnormality. The present approach to diagnosis is categorical. That is, it's either a person meets the criteria or they don't meet the criteria for a particular psychological disorder. Now, one of the things we can do is to get a perspective of where we are in the area of abnormal psychology is to get a look back at where we've been to get to where we are. So we're going to look at a historical view. We're going to do a quick review of the more ancient perspective and move to the more recent past and how we define and support people with psychological disorders. To start, ancient societies attributed abnormal behavior to divine or supernatural forces known as demological model. Stone Age skulls have been shown that their prehistoric ancestors practiced trephining. Trephining is cutting a hole in a person's skull, and possibly as a means of releasing demons. Of course, they don't have a written history entirely, and we don't really know this, but it's one of the assumptions that has been made as to why would you cut a defining hole in one's skull. There are some authorities in ancient times, such as Greek physicians Hippocrates and Galen, who believed that abnormal behavior reflected natural causes. Hippocrates, for example, proposed that abnormal behavior was due to an imbalance in humors, or vital fluids, phlegm, black bile, blood, and yellow bile. The importance of this theory was that it foreshadowed the development of modern medical model of abnormal behavior by which the disorder and disease is seen as resulting from underlying biological processes, and that's essentially the medical model. It was during the Middle Ages that saw a return to the doctrine of possession. Although the belief in possession was known in the ancient Egyptian and Greek writings, it was revitalized by the Roman Catholic Church. As treatment, exorcisms became a common practice in expelling the spirits and demons from affected individuals. Later, beginning in the 15th century, people who displayed abnormal behavior were considered witches. Asylums, or madhouses, began to crop up throughout Europe in the late 15th and 16th centuries, often on the sites of former leprosariums. Conditions in these asylums were dreadful, and in some such In some, such as the Bethlehem Hospital in England, it was a circus atmosphere. People came to watch people suffer. It was kind of a circus. Now, the Hotel Dieu in Quebec City in 1639 was the first asylum in North America. Now, other such places were around at this time. The care was almost non-existent. It was almost like warehousing. With the rise of moral therapy in the 19th century, largely spearheaded by Frenchmen, Jean-Baptiste Poussin and Philippe Pinel, conditions in mental hospitals began to improve. Proponents of moral therapy believed that mental patients could be restored to functioning if they were treated with dignity and understanding. Moral therapy had little to do with any ethical code. Rather, it emphasized treating institutional patients as normally as possible and allowing them the opportunity to interact in normal settings, emphasizing learning social norms. At the same time, this massive immigration that North America was experiencing, Canadian activist Dorothea Dix Crusade began to speak about the conditions of asylums and appalled by the poor standards of asylums. She began what became known as the mental hygiene movement. Now, unforeseen results was that patients were taken out of jails and admitted to asylums. Overpopulation led to further decline of the moral therapy use. It wasn't until the middle of the 20th century did public outrage and concern about the plight of mental patients mobilize legislative efforts towards the development of community mental health centers as alternatives to long-term hospitalization. The Canadian Mental Health Association was created in 1963. The movement towards what was known as deinstitutionalization was spurred by the introduction of psychoactive drugs, in particular phenothiazine, which curbed the more flagrant features of schizophrenia. So as a result, this deinstitutionalization in Canada had resulted in many homeless individuals with mental health issues who got lost in this transition from psychiatric hospitalization to a largely unprepared and inadequate community mental health services. In 2007, the federal government announced funding for the Canadian Mental Health Commission in order to implement a national mental health or mental care strategy. Now, in our current perspective, we're going to look at a few, and we'll do this next week. Abnormal behavior may be viewed from various contemporary perspectives, and we will begin with looking at the medical model, and it conceptualized abnormal behavior patterns like physical diseases in terms of clusters or symptoms. Clusters of symptoms they call syndromes, which have distinctive causes that are presumed to be biological in nature, and that's the medical model. The psychological perspective considers thinking and mental aspects to explain abnormal behavior. The sociocultural view considers the bigger social context. And the interactional perspective, it encourages an interaction of multiple factors: the biological, the psychological, the sociocultural, the environmental factors. This is what we're going to explore in part 2. So we're done the part 1 of this particular video. Part 2 will be in week 1. Take care and good luck. And I hope you're finding it interesting, and we'll get to the individual psychological disorders in a couple more chapters. Thank you, everybody.